Hey everybody, this is Dr. Faro from Alternative Care Wellness Center in Lake Wales, Florida, and we're here with Dr. Faro's Health Tip of the Day. And today, you can see by looking at here, we're going to be talking about the cardiovascular system and cardiovascular risk, specifically the development of plaque and heart attack and or stroke risk. So let's get right into it. People ask me all the time over the past 34 years. I've had numbers of conversations and done dozens and dozens, hundreds of blood assessments and workups on people who are concerned about their cardiovascular risk. We do this as part of what could be an executive physical or someone just coming in for a functional medicine evaluation to look at cardiovascular risk based on what their doctors are told them, or familiar history, or history of heart attack or stroke in the family, what have you. So let's get into it because this is important. What we're looking at here is a model. This is a Pfizer model, and it's representing the blood vessel system here, the vessel system. So we can look at this and let's talk a little bit here. So what I want you to realize, or what I want you to look at, is the vessel system in and of itself. So when we're looking at this, we've got, this is an artery, a cross-section through an artery. We have a intimal layer, the inner layer, okay? Then below that, we have the muscular layer. And then we have a fibrous layer on the outside, which controls the ability of a vessel to constrict or to dilate. And this is under autonomic control through the parasympathetic or sympathetic system. So vasodilation would decrease blood pressure. Vasoconstriction would increase blood pressure. Another interesting point on that as an aside is that as we get older, it's normal for our blood pressure to gradually rise. Say in our 60s and above, a very gradual rise is not that big of a deal because the elasticity of these vessels as we get older changes, and we need a little more pressure to push the blood through it, specifically to perfuse the brain. So here again, we have a normal vessel system, and then down here, we're going to look at a different vessel system, or at a different situation in the vessel system. And what we see is we still see our intimal layer right here. And then we see this white in between the muscularis layer and the intimal layer. That's where the fat deposits. Most of my patients and most people in general think that it's like, calcium building up in your pipe in your house, and that it's building up on the interior walls of the vessel. And that's not the case. That's not what happens. As this expands, we can see there's the intimal layer here, here's the intimal layer here. It's become thickened in this space, and the fatty streak or the glob of cholesterol that has been acted on by a white blood cell, a macrophage in here, it's getting larger and larger, and now the lumen, or the hole for the blood to get through from the artery, is significantly impeded or encroached upon. And then we're going to come down to the final picture or image here, and we see the same thing with a red depiction here. This is a enzyme that leaks out from what we would call a thin wall plaque. And we can test for this enzymatic activity by a blood test, and the blood test is LPLA2 test, and that is a direct indicator of your risk for stroke. Because when you have a situation where you have a thin cap here, the cholesterol can pop out. That could circulate around, get in the brain, and occlude an artery. So now we have a little bit of understanding about what the cardiovascular system looks like and how plaque develops and where it develops. Why does it happen? Well, this is a pamphlet that I've kept in my office for, almost 20 years now. It's just some University of California at Berkeley, and it's a conjunction report done with Quest Labs. And we see a iceberg here, where we have the tip of the iceberg, a significantly smaller portion of the iceberg is above the water, with the massive portion of the iceberg is below the water. Now, how does that relate to what's going on here? And what it's related to, well, let's go back, because it says uncovering the hidden risk for heart attack and stroke. And what we want to talk about is that most of us believe that simply our cholesterol number is the primary indicator that we should be looking at to tell me what, or you or anyone, oh, my cholesterol is 220. Oh, I'm at a terrible risk. I could have a heart attack or a stroke, or my blood cholesterol is at 180. I'm fine. Well, I'm here to tell you that that's not the case. Lipid panel in and of itself is not a good indicator of your risk for cardiovascular disease and stroke. And it has never really been a good indicator, because despite all of our work at and attempts to lower people's cholesterol, we still have a significant rate of heart attack. And in this article, in this paper that we're talking about here, this pamphlet, it says that 72% of the people who were at goal for their lipid and LDL levels, and they still had a first-time MI. So if you're doing something and you're seeing people basically be at goal and that they have an MI, it's not working. And so why is it not working? And the reason why it's not working is because we're not understanding what gets us from here to here, and from here to here, or from here to here. So it's inflammatory. It's the inflammatory process. So this intimal lining, this lining of the inside of the blood wall, a blood vessel wall, when we have a significant inflammation in the system, will cause a weakening, and we find out that these fat globules can migrate through the arterial wall, and they get into the layer just above the muscularis layer, in between the intima and the muscularis layer. At this particular point, the immune system doesn't want them there. Your body doesn't want those fats in that area, and they're acted upon, to make it real simple, by a macrophage, and it creates a foam cell, and then we create this fatty streak, and the more fats and lipids that get in here that the body doesn't want, it tries to isolate them, get them out. We get a larger and larger formation here, and we see occlusion, but again, it's between the intima and the muscularis layer, and this is what's happening. So first of all, you have to have an inflammatory process. How do we monitor inflammation? And does cholesterol have anything to do at the lipid levels, give us any information about what your inflammatory vascular inflammation may be? No. But there are tests that we do routinely to look at this. HSCRP is one of them, high sensitivity or heart sensitive CRP, homocysteine or other levels. There can be genetic factors. We hear these talked about all the time, but we never test for them. Has your doctor ever tested you for a genetic factor, an MTHFR, methyl tetrahydrofolate reductase deficiency, or SNPs? We deal with that, and I can test that in the office as well. And we find that inflammation, genetic factors, and additionally particle size. The size of the particles, the size of the fat globules that are circulating around in your vascular system are important, and there's 5 subfractions of these particle size, from small to large, from a small dense to a large fluffy. And this is also in LDLs and HDLs. So inflammation, genetic predisposition to inflammatory response, particle size, clotting factors such as fibrinogen. So these are the things that we should be looking at to ultimately determine what your underlying risk is for cardiovascular disease and stroke, and not merely looking at just the cholesterol. So we got better images here that we can reference to. We can see again, this is an artist rendition. This is one of the tests I was talking about. Lipoprotein A2 is the only test that can tell you whether or not you have rupture-prone plaque, because it's picking up on an enzyme that's released and makes it through a thin-walled cap, but it doesn't make it through a thick-walled cap. We can see the progression of this inflammatory response as we go to the, I don't know, would it be to your left or your right, but you can see it, a normal artery to the occluded artery. And these are things that we need to look at. So a nuclear magnetic resonance imaging, ApoA-B ratios, NMR, nuclear magnetic lipo panels, MTHFRs, homocysteine, CRP. These are the tests that are going to tell you what your true risk for cardiovascular disease and stroke are. This is lipid testing. This is advanced lipid testing. This is advanced lipid testing for the emerging biomarkers that need to be assessed and looked at. You're doing lipids, you're here. You want to know what's hidden underneath the water that you can't see. Been doing this for a long time. I've sent lots of blood work to medical cardiologists, lots of work out there, and sent my patients back to the cardiologist. We make our recommendations and say, here, bring it to your cardiologist and see what they say. And I've been doing this for probably 25 years, and I do every patient and say, here's your stuff, go back, give it to your GP, give it to your PCP, Give it to your cardiologist. Show them what we're doing. I have not had one doctor come back or patient come back and tell me that the doctor said that we were doing something wrong. They were very impressed. But the question to me, or the question that I have to you, I should say, is if you've been dealing with this, or you've been on a statin, or you've been told that you have a greater risk for cardiovascular disease, and you have never had anything else tested but your lipid levels, then you need to come and make an appointment in my office, and we need to sit down and we need to determine what your true and actual risk for cardiovascular disease is, because lower numbers, you may have a high risk. Higher numbers, as far as your lipid panel, you have no risk. It's not directly correlated. 863-676-2225, drfaro.com. Don't wait another day. And especially women. First-time heart attacks in women kill 50%. So women don't have the classic symptoms that men have. It's, I'm stressed out, I'm too tired, I just don't feel well. And they have multiple small myocardial events over a period of a week to 10 days or so. And then they don't realize they're having a heart attack. And then they get a massive heart attack, and it's not good. So women are at a very high risk as well as men, but the problem is that we're not seeing the same symptoms that we're classically studied and classically talk about that we see in men. So again, Dr. Faro, Alternative Care Wellness Center, Lake Wales, Florida, 863-676-BACK, B-A-C-K, or 2225, drfaro.com. Call, get your appointment. Don't wait. Make your husband do it. I know he won't do it on his own. Take care of your loved ones. Make sure you keep them healthy. This is Dr. Faro. Thank you.